think for a moment about what's really happening when someone is pregnant. I mean, beyond the obvious changes we see, there's this incredible, really intricate dance of biology unfolding inside. A whole new life developing step by fascinating step.
That's absolutely right. And well, this deep dive is all about exploring that whole journey. We're starting right from the very first spark of conception.
Right at the beginning.
Exactly. And following through all the amazing transformations of pregnancy right up to labor and even those crucial initial weeks afterwards.
Yeah, so we'll be looking at the big hormonal shifts, how entire systems in the body have to adapt.
Uh-huh. And the truly remarkable event of childbirth itself.
Our goal here is really to unpack this whole process for you. Shed some light on what's actually going on. We want to point out some of those surprising details that make you say, wow.
And really get the why behind it all. But don't worry, we're keeping things clear, easy to follow, no overwhelming jargon.
Okay, perfect. So let's start where it all begins. Conception and implantation.
Right. So the journey kicks off when a sperm meets an egg. This usually happens in the fallopian tube.
Okay.
And this single cell, now called a zygote, it starts about a week-long trip down towards the uterus. But it's not just like floating along.
It's already changing.
Oh, absolutely. It's rapidly dividing, changing, becoming this structure we call a blastocyst.
And this blastocyst, it's not just a random clump of cells, is it? It's got a plan.
Exactly right. It's quite clever, actually. It develops two main parts. One part is destined to become the embryo and eventually the fetus. And the other part, that forms the placenta, which is this essential organ we'll definitely talk more about.
Okay, so it reaches the uterus, then what?
And it needs to settle in. This is implantation. It basically burrows into the lining of the uterus. And this moment, this implantation, it triggers an immediate hormonal signal.
Hormones, like the body's instant messengers, right. What's the urgent message being sent here?
But the main message is stop menstruation. The body knows it needs to keep that uterine environment stable for this developing blastocyst.
Makes sense.
And at the same time, something called the decidual reaction happens. The cells lining the uterus actually change, they get larger, and they provide a sort of anchor for the blastocyst.
It's anchor. Okay.
Yeah, and it's also the very beginning of this kind of chemical conversation, this crosstalk between the pregnancy and the pregnant person's body.
Wow. Okay, so that's the initial spark, the setup. Now, moving into early pregnancy, say the first couple of months, like weeks 1 through 8, it sounds like the hormones really, really take center stage now.
Oh, absolutely. Very quickly after conception, the cells that are going to form the placenta start churning out a hormone called human chorionic gonadotrophin, HCG.
That's the one the pregnancy tests look for.
That's the one. Home pregnancy test detected in urine. Now, it builds up pretty fast in the blood, but it usually takes about maybe 3 to 4 weeks from the last period before it's concentrated enough to show up on a standard urine test.
So that little test stick is basically listening in on those early placental cells.
Precisely. And as these pregnancy hormones climb higher and higher, often around the second month, say weeks 5 to 8, that's usually when the pregnant person really realizes, okay, I'm pregnant.
And that hormone surge is also behind many of those classic early symptoms, right?
Yes, exactly. The fatigue, the nausea, that's the hormones going into overdrive.
The ones everyone talks about. But at the same time, there's so much critical development happening with the embryo itself, isn't there? It's not just about feeling a bit off.
Not at all. Week 5 is huge. The neural tube forms, this is the precursor to the brain, the spinal cord, the whole central nervous system.
Wow.
And get this, by the end of this week, the tiny heart tube, it starts to beat really rapidly, around 110 beats per minute.
Already. That's incredible. A tiny heart beating so fast. What about week 6?
Week 6, you start seeing little buds pop out.
Yeah.
These will eventually become the arms and legs. Blood cells are starting to form. The beginnings of a circulatory system are being laid down. And you also see the structures taking shape. That will become the ears, eyes, and mouth. And sometimes, with a special vaginal ultrasound, a doctor might even be able to detect those tiny heart pulses.
That is just amazing progress in only a few weeks. Week 7.
Week 7, bone starts replacing cartilage. The genitals begin to form. Interestingly, the embryo's head looks quite large compared to the rest of the body this stage.
Disproportionate, yeah.
Very. Some people even describe the look as like a tiny tadpole or maybe even a seahorse, partly because there's a prominent tail structure that eventually disappears.
A seahorse. That's not an image you hear often. Okay, and by week 8, what's developed?
By week 8, all the major organs and body systems are actively developing. You've got webbed hands and feet, the eyes are visible, ears are forming,
Wow.
and crucially, the umbilical cord is now fully developed. This is that vital link for oxygen and blood transport.
The lifeline.
Exactly. And around this time, the placenta also starts secreting another key hormone, human placental lactogen, or HPL. You can start detecting this in the pregnant person's bloodstream around 6 to 8 weeks, and the levels just keep rising as the placenta grows bigger.
The placenta really sounds like the unsung hero here. Let's dive into that a bit more. What else is this vital organ doing besides making hormones?
Well, first, that uterine lining, the decidua as we call it in pregnancy, it does more than just anchor. It actually helps guide how the outer layer of the blastocyst, the trophoblast, implants and sets itself up.
Okay.
But fundamentally, like you said, the placenta establishes this uteroplacental circulation. Think of it like a bustling marketplace.
Okay, I like that analogy.
Yeah, and the uteroplacental circulation is the complex network of roads connecting everything. It allows for this constant exchange. Oxygen and nutrients go into the baby.
And waste products going out.
Exactly. Waste going out.
Yeah.
And for the fetus to get the oxygen it needs, 4 things are really critical.
4 things, okay.
1, enough maternal blood flowing into the placenta. 2, healthy placental structures, these things called villi, where the exchange actually happens. 3, efficient transport of gases, nutrients, waste across those villi. And 4, good circulation within the fetus itself and through the umbilical cord.
So it's a really intricate system. Everything has to work together perfectly.
Precisely. It's a delicate balance.
And we heard about that hormone HPL earlier. What's its main job again?
Right, HPL. What's fascinating is that it actually causes the pregnant person to become slightly more resistant to insulin.
Insulin resistant. That sounds not good.
Well, it sounds counterintuitive, but it's actually a brilliant adaptation.
Yeah.
This slight resistance ensures that the developing fetus gets first dibs, essentially, on the glucose supply.
Ah, so the baby gets the fuel it needs.
Exactly. Glucose is its primary energy source. It's a clever way to prioritize fetal needs, but it's a balance, like I said. If this resistance goes too far, that's when gestational diabetes can develop.
I see. And does insulin itself cross the placenta?
Good question. No, it doesn't. Glucose crosses easily, but the mother's insulin stays on her side.
Okay. The placenta sounds absolutely crucial, but I guess things can sometimes go wrong with it.
Unfortunately, yes. The very early stages of placental development are actually where the origins of several pregnancy complications lie, things like preeclampsia. Even if the symptoms don't show up until much later in the pregnancy, the groundwork might have been laid very early on.
And what about the immune system? I mean, the fetus is technically foreign material, isn't it? Half from someone else. How does the body not reject it?
That's a fantastic question, and it's one of the immunological marvels of pregnancy. You're right, the fetus is like a semi-allogenic graft, half genetically different.
So why doesn't the immune system attack?
A few key reasons. One is that the outer layer of the placenta, that trophoblast we mentioned, it doesn't display the usual red flag signals that would normally alert the maternal immune system. It's kind of immunologically privileged.
Still.
Sort of. And also, those pregnancy hormones we keep talking about, they actually help modify the pregnant person's immune response, promoting tolerance rather than rejection.
So the immune system is dialed down a bit. Or changed.
It's more nuanced than just dialing down. We actually see a concentration of specific immune cells called natural killer cells, or NK cells, in the uterine lining during pregnancy.
Natural killer cells, that sounds aggressive.
The name is a bit misleading in this context. Here they have a gentler role. They actually help control how deeply the placenta implants, and, importantly, they assist in remodeling the blood vessels in the uterus to ensure good blood flow.
Okay. So they're constructive helpers here.
Exactly. And interestingly, other key immune cells like T cells and B cells become less common right there in the uterus during this time.
Fascinating.
Yeah.
But can things disrupt this immune balance?
Yes. Factors like obesity, for instance, can affect how the placenta develops right down to the genetic level. Research shows it can lead to signs of metabolic stress and inflammation in the placenta itself, which might ultimately impair the delivery of oxygen and nutrients to the fetus.
It really underscores how interconnected everything is. Okay, let's shift focus now to the pregnant person's body itself. The changes are obviously profound. Where should we start? Maybe the cervix.
Good place to start. The cervix undergoes some really remarkable transformations. It starts to soften pretty early on, maybe around 4 weeks after the last period. This softening is called remodeling, and it's actually one of the early signs a doctor or midwife might pick up on during an exam. It's called Goodell's sign.
Goodell's sign. Okay. And there's a color change, too.
Yes, as blood flow to the whole area increases dramatically, the cervix and vagina can take on a sort of bluish-purple hue. That's called Chadwick's sign, usually visible around 6 to 8 weeks.
Visual cues that things are definitely changing. What's the cervix normally like?
Well, when not pregnant, the cervix is usually about 3 centimeters long. It's the lower, narrow part of the uterus that opens into the vagina. It has an outer part you can see and an inner canal,
And hormones make it soften.
primarily estrogen. Estrogen works on the collagen fibers within the cervix, making them softer and more pliable. This initial softening is really just preparing it for the much more dramatic changes needed for labor later on.
Okay. Moving up from the cervix, let's talk breathing. I know so many pregnant people mention feeling short of breath. What's going on there with the respiratory system?
Yeah, that's very common. Several things contribute. Early on, those pregnancy hormones can affect the blood vessels in your nasal passages.
Making you feel stuffy.
Exactly. Congestion is common. It can even change your voice a bit and maybe make you slightly more prone to upper respiratory infections. It also means, clinically, that if intubation is needed, a smaller tube might be required, and there's a higher risk of bleeding.
Interesting practical effect. What about the lungs themselves?
Well, later in pregnancy, as the uterus grows significantly, it pushes the diaphragm, that big muscle under your lungs, upwards by about 4 centimeters.
4 centimeters. That must reduce lung space.
It does slightly decrease the total lung capacity,
Yeah.
but the body compensates cleverly. The diameter of the chest actually increases by maybe 5 to 7 centimeters, and the ribs flare out a bit.
So your rib cage literally expands.
It does. There's also a gradual decrease in some specific lung volumes, like how much air you can forcefully exhale.
Yeah.
But surprisingly, the actual elasticity or compliance of the lungs doesn't really change.
So even with these changes, why the breathlessness?
It's likely multifactorial. There's an increase in minute ventilation, the total amount of air you breathe in and out per minute. There's also more blood flowing through the lungs. This might make the body sort of more sensitive to changes in carbon dioxide and oxygen levels.
making you feel like you need more air.
Potentially, yes. And then, of course, especially in the later trimesters, that large uterus physically restricts diaphragm movement, which definitely contributes to that feeling of breathlessness. Also, progesterone seems to stimulate breathing, leading to a kind of mild hyperventilation.
Hyperventilation.
Mild, yeah. Results in what's called respiratory alkalosis, which actually helps transfer carbon dioxide away from the fetus more effectively. And estrogen contributes to swelling in the nasal passages too, adding to that congestion feeling.
Wow, the body is constantly adapting and balancing. Okay, let's go even further up the mouth. Any changes there?
Yes, bleeding gums are very common, especially after brushing. This is again due to those hormones, estrogen and progesterone, causing inflammation and increased blood flow or hyperemia in the gums.
Making them more sensitive.
Exactly. And higher estrogen levels can also create a better environment for certain bacteria that cause gingivitis or gum inflammation to grow. So, good oral hygiene and regular dental visits are really quite important during pregnancy.
Good advice. Now, with everything shifting inside, I imagine the digestive system feels the effects too. Constipation is common, right?
Oh, very much so.
Mm-hmm.
Progesterone is the main player here again. It tends to slow down peristalsis, those wave-like muscle contractions that move food through your intestines.
Slows things down.
Right. And the body also tends to reabsorb more fluid from the bowel, which can make stools harder. Put those together, and the risk of constipation goes way up. Plus, the growing uterus physically displaces and compresses the bowel, which doesn't help movement either.
Where does everything go?
Generally, the stomach gets pushed upwards, and the intestines tend to get shifted more towards the sides and back. It's a bit of an internal Tetris game.
Huh. Internal Tetris. Okay, what about the engine room? The heart and blood vessels. The cardiovascular system must be working overtime.
It really is. The heart itself actually gets slightly bigger. This is due to a combination of hypertrophy, where the muscle cells enlarge, and some dilation or expansion of the chambers.
So the heart physically enlarges?
Slightly, yes. And because of this, and the diaphragm pushing up where you feel the heartbeat, the apical impulse, might shift a bit upwards and to the left. Sometimes mild leakage through the tricuspid valve can occur too. Usually nothing serious.
And it's pumping more blood.
Significantly more.
Yeah.
Heart rate increases, the amount of blood pumped with each beat, that stroke volume increases, and the total cardiac output, the amount pumped per minute, goes up substantially.
How much are we talking?
By the end of the first trimester, cardiac output can be 30 to 40% higher than pre-pregnancy levels. This is mostly due to a big jump in stroke volume, about 35%, and a smaller increase in heart rate, maybe 15%.
Wow. What about blood pressure? Does that go up too?
Interestingly, no. The
Mm-hmm.
overall resistance in the blood vessels throughout the body, systemic vascular resistance, actually decreases.
Decreases. Why?
Hormonal effects, particularly progesterone, relax the smooth muscle in blood vessel walls. So even though the heart is pumping much more blood, the pressure doesn't necessarily rise. It might even dip slightly mid-pregnancy before returning towards normal near term.
That's fascinating. So less resistance. What about pressure in the veins?
Central venous pressure near the heart doesn't change much, but femoral venous pressure down in the legs definitely increases. That's mostly due to the mechanical pressure from the growing uterus on the large veins returning blood from the legs.
Explains swollen ankles sometimes?
Exactly. So overall, you have reduced afterload, the resistance the heart pumps against, and increased preload, the amount of blood returning to the heart. The heart's output also varies depending on position.
How so?
It's generally highest when the person is in a knee chest position or lying on their left side, and lowest when standing or lying flat on their back, because the uterus can compress major blood vessels in the supine position.
Good to know. And labor itself puts more strain on the heart.
Yes, during labor, cardiac output increases further. This is due to pain and anxiety releasing catecholamines, stress hormones, and also because each contraction squeezes blood out of the uterus back into the general circulation.
And right after birth.
Immediately postpartum, there's another surge, potentially up to a 50% increase from pre-labor levels. This is partly due to autotransfusion as the uterus clamps down and blood returns to the central circulation. The system adapts remarkably quickly, though.
It truly sounds like the cardiovascular system is doing an incredible amount of adaptive work. What about the blood itself? Its composition must change too.
Absolutely. Total blood volume increases dramatically by about 30 to 45%.
30 to 45% more blood.
Yes, but here's the interesting part. The plasma volume, the liquid part, increases more than the red blood cell mass. Plasma goes up about 45%, while red cells increase around 33%.
So the blood gets diluted.
In a way, yes.
Yeah.
It leads to what we call hemodilution, or sometimes the physiological anemia of pregnancy. Hematocrit, the percentage of red blood cells, naturally drops a bit. Same for plasma protein and albumin concentrations.
But what about clotting? I hear pregnancy increases clotting risk.
That's true. Many clotting factors, specifically factors I, which is fibrinogen, 7, 8, X12, and others like von Willebrand factor, actually increase significantly. Fibrinogen can go up by 50 to 80%.
Making the blood clot more easily.
Exactly. It's thought to be a protective mechanism against excessive bleeding at delivery. But it does mean a higher risk of blood clots, like DVT or pulmonary embolism, during pregnancy and postpartum.
Okay. What else changes in the blood?
Erythrocyte sedimentation rate goes up. Serum lipids, fats in the blood increase quite a bit, 40 to 60%. The kidneys produce more erythropoietin, stimulating red blood cell production. And there's an increase in a substance in red blood cells called 2Le3-DPG.
2-3-DPG. What does that do?
It helps red blood cells release oxygen more easily to the tissues and, importantly, to the placenta and the baby. It shifts the oxygen-hemoglobin dissociation curve to the right.
Clever. Are there things that don't change much?
Yes, quite a few things stay relatively stable, like the amount of hemoglobin within each red cell, lymphocyte counts, though their function might be slightly reduced, bleeding time, platelet count, standard clotting times like PT and APTT, and plasma oncotic pressure. White blood cell count does tend to increase moderately, though.
It's such a complex picture of adjustments. What about the kidneys dealing with all this extra blood volume and waste filtering?
Well, that increased cardiac output means significantly increased blood flow to the kidney's higher renal plasma flow. And the rate at which the kidneys filter blood, the glomerulose filtration rate, or GFR, goes up too, by as much as 50% by term.
50% increase in filtration.
Yes, which is why levels of waste products in the blood, like BUN and creatinine, actually decrease. They're being cleared out more efficiently.
So the kidneys are working harder, but more effectively in a way.
Exactly. However, this supercharged filtration can sometimes overwhelm the kidney tubule's ability to reabsorb everything useful.
Like what?
It's like glucose and amino acids. So it's not uncommon to find small amounts of glucose in the urine, maybe up to 300 milligrams a day, which is called glycosuria, and some aminoaciduria too. It's usually mild and doesn't necessarily mean diabetes.
Okay. And after birth?
In the first few days postpartum, typically days 2 to 5, there's often a significant diuresis, increased urination, as the body gets rid of all that extra fluid accumulated during pregnancy. The GFR and waste product levels usually return to non-pregnant levels by about 6 weeks postpartum.
The body really does reset itself. We've touched on hormones like HCG, estrogen, progesterone, HPL quite a bit. What's the bigger picture with the endocrine system, the hormone control center?
Well, all those pregnancy hormones we've discussed naturally alter the overall hormonal milieu. For example, that early surge of base HCG can actually weakly stimulate TSH receptors on the thyroid gland.
Affecting thyroid function.
It can, potentially causing a temporary mild hyperthyroidism, sometimes called transient hyperthyroidism of pregnancy. You might also see a slight enlargement of the thyroid gland itself. Also, the liver produces more thyroid-binding globulin, the protein that carries thyroid hormones in the blood.
So total thyroid hormone levels might look higher.
They might, but the levels of free active T3 and T4 usually remain within the normal range, which is what really matters for function.
Okay. And blood sugar regulation, we mentioned insulin resistance.
Right, so fasting blood sugar levels actually tend to be lower in pregnancy. But as we said, the body's tolerance to a glucose load can be impaired, partly due to HPL creating this sort of mild diabetogenic state. That early glycosuria we mentioned can happen partly because of this, alongside the increased kidney filtration.
So lower fasting sugar, but potentially higher sugar after eating.
Exactly. That lower fasting glucose can sometimes mask the underlying insulin resistance caused by HPL and other hormones like progesterone, prolactin, and cortisol. This is why screening for gestational diabetes is so important.
Because glucose crosses the placenta, but insulin doesn't.
Precisely. If the mother's blood sugar is high, the baby gets excess glucose, produces extra insulin, and can grow very large macrosomia and then potentially have low blood sugar, hypoglycemia, and even seizures after birth when the maternal glucose supply is cut off.
A serious risk. Does it resolve after birth?
Yes, usually glucose responses normalize quite quickly after the placenta is delivered, since it was the source of hormones like HPL causing that insulin resistance.
It really is all about that placenta in many ways. Okay, what about other systems? Are there, say, neurological changes, skin changes, eyes?
Yes, there can be changes across the board. Neurologically, some studies suggest an increase in cerebrospinal fluid pressure. The veins in the epidural space, where epidurals are placed, become engorged, which can make epidural spread differently or require less anesthetic dose. Sensitivity to local anesthetics might increase too.
Okay. And skin. Stretch marks are famous.
Yes, stria gravidarum, or stretch marks, are very common as the skin stretches rapidly. Also, hyperpigmentation is frequent darkening of the skin on the face, melasma or mask of pregnancy, the nipples, and a dark line down the abdomen called the linea nigra. This is due to increased melanocyte-stimulating hormone.
What about eyes? Anything happen there?
Some people experience changes. There can be a slight decrease in the production of aqueous humor, the fluid inside the eye, which might lead to a small decrease in intraocular pressure. Contact lens tolerance might also change for some.
And metabolically, we talked glucose, but overall?
Overall, metabolism increases to support both the pregnant person and the growing fetus. There's increased turnover of carbohydrates, proteins, and fats. That insulin-resistant state we discussed, driven by HPL, progesterone, prolactin, and cortisol, plays a key role in directing nutrients, especially glucose, towards the fetus.
It's truly a whole-body transformation, recalibrated for this specific purpose. Okay, let's move toward the culmination of all this. Labor and birth. This is another process with distinct stages, right?
Absolutely. Labor and birth are typically divided into three main stages. The first stage is the longest and is all about the cervix opening up or dilating to allow the baby to pass through.
And this first stage has its own phases.
It does. It usually starts with the latent phase. This is the early, often slower part. Contractions are typically mild, maybe irregular, sometimes feeling like period cramps or a dull backache. During this time, the cervix starts to thin out. That's called effacement, and open, maybe up to about 3 or sometimes more centimeters. Definitions vary a bit.
What should someone do during this latent phase?
Generally, rest, stay hydrated, maybe some light activity if you feel up to it. It's about conserving energy.
Okay, the warm-up. Then it gets more serious.
Then comes the active phase. This is when things really pick up. Contractions become stronger, longer, and more frequent, maybe every few minutes. The cervix dilates more rapidly now, typically from around 4, 5, or 6 centimeters again. Definitions differ slightly, up to maybe 7 or 8 centimeters.
And this is when labor sensations become much more noticeable.
Yes, definitely. This is often when people start using more focused coping strategies or consider pain relief options, whether that's breathing techniques, movement, massage, water immersion, or medical options like an epidural.
And after the active phase?
Comes the transition phase. This is usually the shortest, but often the most intense part of the first stage. Contractions are very strong, very close together. The cervix finishes dilating fully to 10 centimeters.
10 centimeters is fully dilated.
Correct. And during transition, many people feel a really strong urge to push, along with maybe shaking, nausea, or feeling hot and cold. It can be overwhelming, and having good support is crucial here.
That sounds intense. How long does this whole first stage take?
It varies hugely, especially between a first baby and subsequent babies. It can be many hours, particularly the latent phase.
Okay, cervix fully open. That brings us to the second stage.
Exactly. The second stage begins with full cervical dilation and ends when the baby is born. This is the pushing stage, where contractions help move the baby down through the birth canal and out.
The arrival.
Yes, the expulsion of the infant. The length of this stage also varies, often shorter for subsequent births.
And after the baby is born, there's still one more stage. People sometimes forget this one.
That's right, the third stage. This is the delivery of the placenta. After the baby is born, the uterus continues to contract, helping the placenta detach from the uterine wall so it can be delivered. This is a really vital final step to prevent excessive bleeding.
So, first stage, dilation. Second stage, baby's birth. Third stage, placenta delivery.
Got it. But I've also heard childbirth described sometimes with 4 stages, especially focusing on that time right after birth.
Yes, that's often used. The fourth stage generally refers to the immediate postpartum period, the first hour or two after the placenta is delivered. It's a critical time for monitoring both the mother, especially for bleeding, and the newborn as they transition to life outside the womb.
And this is when that skin-to-skin contact is key. Absolutely. Major health organizations strongly recommend placing the baby, stable and dried, directly skin-to-skin on the mother's chest immediately after birth, assuming both are well. This should ideally happen before any routine procedures, like weighing or bathing, for at least the first hour or two, or until after the first breastfeeding.
Why is that immediate contact so important?
So many benefits. It helps regulate the baby's temperature, heart rate, and breathing. It calms both mother and baby, reduces stress hormones, promotes bonding, and importantly, it encourages the initiation of breastfeeding. The baby often instinctively finds the breast during this time.
That's amazing. What if the mother can't do skin to skin right away, say after a C-section?
Then the other parent or a designated support person can absolutely provide that skin-to-skin contact.
Mm.
It's still incredibly beneficial for the baby. The World Health Organization even advises against even brief separations before that first feed, if possible, to really support that bonding process. Frequent skin-to-skin is recommended throughout the early days.
Okay. How long do people typically stay in the hospital after giving birth? It seems to vary a lot.
It really does vary significantly depending on the country, the type of birth, hospital policies, and individual circumstances. The WHO recommends at least 24 hours after an uncomplicated vaginal birth and 96 hours, 4 days, after a C-section for monitoring. But actual average stays can range from less than a day in some places to maybe 6 days in others. In the U.S., it's typically around 2 days for a vaginal birth.
Now, we can't really discuss childbirth without acknowledging the pain or intense sensations involved. What do we understand about the experience of labor?
Well, the physical sensations are obviously intense, driven by uterine contractions and the stretching of the cervix and birth canal. But the experience of that pain is incredibly subjective and influenced by many factors.
Like what?
Culture plays a big role in how pain is expressed and managed. Prior birth experiences matter often. Subsequent labors are perceived as less painful, perhaps partly due to reduced fear and anxiety. The level and type of support received during labor is hugely important.
And how people cope varies too.
Absolutely. Pain management runs the gamut from medical interventions like epidural anesthesia, which is very effective for many, to non-pharmacological methods like breathing techniques, relaxation, massage, movement, water immersion. The Lemay's method is one well-known approach focusing on coping techniques.
And hormones play a role in the emotional side too. You mentioned oxytocin earlier.
Yes, oxytocin, often called the love hormone or bonding hormone, levels rise towards the end of pregnancy, promoting feelings of calm and contentment. During labor, levels surge even higher with cervical and vaginal stimulation from contractions and the baby's descent.
And that helps with.
It's believed to be crucial not just for driving contractions, but also for facilitating mother-infant bonding immediately after birth and promoting nurturing maternal behaviors.
Right.
Interestingly, fathers or partners also experience a rise in oxytocin after interacting with their newborns. And of course, breastfeeding triggers further oxytocin release, which helps with milk letdown and uterine contraction postpartum.
It's fascinating how hormones orchestrate not just the physical process, but the emotional and bonding aspects too. Okay, finally, let's touch on that postpartum period itself, the weeks after birth. What are the key things happening then?
The postpartum period, traditionally considered the first 6 weeks after birth, though recovery can take longer, is a really significant time of recovery and adjustment. Physiologically, the mother's body is gradually returning towards its non-pregnant state. Hormone levels are shifting dramatically, the uterus is shrinking back down in evolution, and other systems are readjusting.
And the baby is adjusting too.
Absolutely. The newborn is making huge adjustments to life outside the womb, breathing air, regulating temperature, feeding, and eliminating waste independently.
It sounds like a vulnerable time.
It is. The WHO actually calls it a critical but often neglected phase. Sadly, the risk of death for both mother and infant is higher during this period than at many other times. We've mentioned skin to skin, which is vital. Another major concern is postpartum hemorrhage, excessive bleeding after birth.
How common is that?
It's the leading cause of maternal death globally. About two-thirds of those deaths are attributed specifically to postpartum hemorrhage. There are several potential causes, often remembered by the 4Ts. Tone, uterine atony, where the uterus doesn't contract well. Trauma, lacerations or rupture. Tissue, retained placental fragments. And thrombin, coagulation problems.
So physical recovery is huge. What about the emotional side?
Equally huge. It's a time of intense emotions. While joy is common, it's also very normal to experience significant mood fluctuations. The baby blues, characterized by mild unhappiness, weepiness, anxiety, feeling overwhelmed, are extremely common, affecting up to 80% of new mothers. They usually peak in the first few days and resolve within a week or two.
But sometimes it's more serious.
Yes, postpartum depression is a more severe and persistent condition, involving deeper sadness, anxiety, loss of interest, and difficulty functioning. It affects around 15% of mothers and requires treatment and support. There's also postpartum anxiety and, in rare cases, postpartum psychosis. And we should also mention tuchophobia, a significant fear of childbirth itself, which can affect a notable number of people during pregnancy and impact their postpartum experience too.
It's so clear that pregnancy, childbirth, and postpartum are truly monumental life events marked by this incredibly complex, beautifully orchestrated cascade of changes.
Absolutely. It's just staggering when you think about it. From that single fertilized cell and those initial microscopic developments through the 9 months of the body's remarkable adaptation to the powerful event of labor and birth and the adjustment period after. It's an incredible testament to biology, to resilience.
Right, the sheer adaptability of the human body to nurture and bring forth new life. It's just amazing.
It really is.
So as you reflect on all these profound transformations we've discussed, maybe just take a moment to consider that adaptability. Understanding these changes, even just grasping the basics like we've talked about today, can hopefully lead to better care, maybe greater appreciation, and just a more informed experience for everyone involved, whether you're going through it, supporting someone, or are simply curious.
Well said. And if any particular change we mentioned today, maybe the respiratory shifts or the immunology of the placenta sparked your curiosity, definitely explore it further. There's always more to learn.